Hello, everybody, and welcome to this patient and family webinar. I'm Patrick Flume. I'm from Charleston, South Carolina, at the Medical University of South Carolina. This is part of our meeting that we had this last night and today that we call the Southeastern Consortium for Bronchiectasis and NTM. And I first want to thank our sponsors who, with their support, has made it so we could put on this program as well as have our consortium meetings. So a big shout out to INSMED, Paratech, Sanofi, Synchrony, the Bronchiectasis and NTM Association, and NTMIR. So thank you to them. I just want to say briefly about the Care Center Network, which is sponsored by the Bronchiectasis and NTM Association. This was a project that was launched last year in which 33 sites were joined in a care center network. Second round of applications has just went out. So the intent is to grow the care center network to be able to provide specialty centers all across the US for patients who suffer from bronchiectasis and NTM. The meeting that we're having today is the sites that are in the Southeastern region. So that lower right quadrant of the US, we pulled together the 12 sites together to talk about ways in which we could share and collaborate with the hopes of benefiting the patients that we serve. So from that, we are having this webinar, and I've invited speakers from around this region so you can see that they're all coming from different sites within the Southeast, covering a myriad of topics. I'm going to let each one introduce themselves as we start. And so without further ado, I'm going to invite up our first speaker to talk about NTM in the environment.
Greetings, everyone. It's my pleasure to be here and to present with you today. I'm going to talk a little bit about non-tuberculous mycobacterial infection and the environment, with the caveat that while much of what I'm going to talk about is true, there's some debate about how clinically relevant some of this information is. And in fact, some evidence seems very clear-cut, others not so much. And so I'm going to highlight some of that as we go along. But again, I'm Colin Swenson. I am at Emory in Atlanta, where I run the Bronchiectasis and NTM lung disease clinic. So just an overview of non-tuberculous mycobacteria. So these organisms are ubiquitous in the environment. I oftentimes get asked in clinic, well, how can I avoid NTM? The short answer is it's nearly impossible to avoid NTM in the environment. They're ubiquitous, they are in water, they're in soil, they are in house dust, in fact. They are opportunistic pathogens. And what that means really is that in the normal, intact, immunocompetent host, they typically do not cause disease. However, in some people, as we know, that is not necessarily so. So these organisms can get in there, they can stick, and they can in fact cause significant symptoms, as you all are aware. The organisms can affect the lungs, of course, as well as the skin, the bone, the lymph nodes. In some very, very severe cases in immunocompromise, the infection can essentially affect all body systems. We have a number of proven sources of infection. This includes fresh water, or even brackish water in some cases, soil, dust mites, as I mentioned, and some other sources that we'll talk about as we go along. In terms of transmission, it's thought that water aerosolization, particle inhalation from soil dust, certainly food, water consumption with gastroesophageal reflux and aspiration, which oftentimes happens at night when patients are completely unaware of it, are thought to be important source causes of infection. And I include this slide not as an intro to microbiology, but more just to highlight the fact that NTM are extremely hardy organisms. And that's because they have a very thick, waxy cell wall that's really rich in what we call mycolic acids. And what this does is it makes them very hardy in different environmental niches. They can resist acids, they can resist alkalis, detergents, They can resist the oxidative burst, which is part of the innate immune response of your own immune system. So they're very, very hardy. On top of it, this thick, waxy cell wall also makes them hydrophobic. And that's important because, as we will see, they can disperse from water surfaces and into the environment. And this is just sort of a pictorial representation of this. And so we think that how NTM get into the water supply really starts at sort of the environmental or surface water source. And you can see here represented by the water skeeter sort of gliding on top of the water, that really the hydrophobic nature of these organisms allow them to sort of float on the water surface, adhere to other particles that may get there, and then of course when this is disrupted, they become dispersed. Of course, this water supply feeds into the municipal water system. So it goes into a water treatment plant. The water treatment plant, while very good at sort of ridding our water supply of a number of different chemicals and contaminants, does very little to exclude NTM organisms. Those NTM organisms then, of course, make their way into our household water supply. And I put a shower here with steam just as a representation. Some work by some of my colleagues here, in fact, show that likely showers are safe, but again, that is a matter of debate. This is work done by Joe Falkingham out of his lab that showed non-tuberculous mycobacterial isolated from household plumbing of patients with known pulmonary non-tuberculous mycobacterial disease. And what they saw was that in almost half of cases, the households with NTM isolated from the NTM sources from their water supply matched that of the patient. And that would seem to demonstrate that there is a correlation between the water that's within the household and what is isolated from the patient. Other work by some of my colleagues, again, some of them in this room, have shown less of a correlation. And so we think that there might be some regional variation in that. And this is work that was done out of the NIH in the mid 2010s that showed that NTM prevalence with geographic variation among Medicare beneficiaries. And what this map shows really is that NTM infection tends to be densest or highly clustered in certain areas of the country. Right now we are in the Southeast, and you can see that it's an area of very high endemicity of NTM lung disease. There were some factors that were also associated with increased prevalence of NTM lung disease, including greater population density, areas with a greater population density, areas with high surface fresh water, areas with higher mean precipitation and mean daily evapotranspiration, which is a very fancy term of way of talking about total dissolved water in the environment. Areas with lower elevation, such as where we are right now, and also areas with a municipal water supply. And that led to questions about whether sort of trace metals or disinfectants were somehow also associated with this NTM infection risk. Some newer data out of the NIH has actually taken that to the next level, which is looking at trace metals within the water supply and NTM infection. And in fact, in the West, it was found that there was roughly a 30% increased risk of MAC infection for every 1 unit increase in molybdenum, which again is a metal, trace metal in the water supply. In the Northeast, there was a marked increase risk of MAC infection in vanadium. And in the Southeast, there was also an increased risk of abscessus and vanadium in the water supply. So again, this does not necessarily imply causation, but there's certainly some correlation there that make it worthy of further investigation. Some soil sources that we know of. Again, most of this is out of the Falkingham lab, but in some forms of soil, particularly bagged potting soil that we find at garden convenience stores nationwide, there are up to 1 million NTM organisms per gram of soil. So very, very high concentration. It tends to be highest in peat-rich soils, loamy soils, and swamps. And that's why I included the picture of a Florida swamp at the very top. As I mentioned before, these organisms, because they're hydrophobic, they adhere to particles very, very well, and they disperse very well in air. And as I mentioned before, there's correspondence between soil isolates and infecting organisms in some case series. So in summary, NTM lung disease prevalence is certainly increasing. In clinic, we always strive to do a careful exposure history and an environmental survey to see if there's any way that we can reduce the risk of reinfection. Again, not helpful in some cases, but not in all cases. And really, the takeaway is that further work that is already in progress is needed in order to define risks a little bit better. And with that, I will pass the baton to talk about diagnosis of NTM lung disease.
Thank you. And I just wanted to step in for one moment to make sure that I'm letting everybody into the meeting. Okay. And also I failed to tell you that if you have questions, write them in the chat and we will do our best to answer them at the end of the session. Okay.
Hi, my name is Shelby McRae, and I am the Center Director for NTM and Bronchiectasis at LSU in New Orleans, Louisiana. And I am going to be talking about the diagnosis of NTM lung disease. So Dr. Swenson just covered this nicely for us, so hopefully everyone knows what NTM are. They are non-tuberculous mycobacteria. And I like to show what we're talking about here. So when we say non-tuberculous mycobacteria, if you remember to maybe middle school biology class, when we go over these domains and kingdoms, we're talking about this genus, so this group of bacteria called mycobacteria. And we're taking out tuberculosis and we're taking out the bacteria that causes leprosy. And everything that we're left with is what we call NTM, or non-tuberculous mycobacteria. Dr. Swenson just talked about some of this with us, which is that they are transmitted from the environment to the person. So unlike tuberculosis and unlike leprosy, which are transmitted person to person, these are coming from environment to person, which I agree. A lot of times, one of the first questions I get is, if I cough in front of my family member, in front of my loved one, in front of my grandchildren, am I going to give them this disease? And the answer is generally no, these are not contagious. It's environment to person. And if that's the case, then why did I become infected with NTM? And the short answer is that it's really complicated. And there's a lot of different factors that go into why we're all exposed to this, but only some of us get infected. Like Dr. Swenson just went over, there are a lot of different environmental and geographic factors. This is the Southeast Consortium, and the Gulf South in general, as well as pretty much any coastal areas, do tend to have higher rates of infection, hot, humid places. Age, we know that as people get older, the risk of getting infected with these bacteria does get higher. Being underweight is associated with higher rates of infection, especially if your body mass is less than 18.5, which is why a lot of times in clinic we'll be talking about your nutrition and trying to gain weight. There's different genetic mutations that you may have just been born with that made you at increased risk for getting this infection, as well as the most important risk factor here is having an underlying lung disease, especially bronchiectasis, which is why this webinar is about both bronchiectasis and NTM, but other lung conditions can put you at increased risk as well, like asthma, COPD, interstitial lung disease. We don't fully understand why, but we know that females are more likely to get infected and to have this than males. If you have issues with your immune system, either because you're on medications that affect your immune system or because you're born with not as strong of an immune system as others, that can affect it as well. And of course, having other medical conditions, being on certain medications can put you at risk. So again, it's really complicated and absolutely not your fault, nothing that you did to get infected with this. Don't be scared by this slide. This slide's just to show you that there's a lot of different NTM. There are actually over 200 different species and subspecies. And I bring that up because you may hear different names. This is just a handful of names of different mycobacteria. Probably the most common that people in this webinar may have suffered from infection with are those in the MAC group and those in the Mycobacterium abscessus group. The ones with the little star here are ones that we find commonly, but they're not as common to cause lung disease. And I'll talk about that a little bit more in a couple more slides. So these tend to be the ones that cause more infections in people, although this is not a comprehensive list. Again, the comprehensive list is actually a little intimidating if you really look at it. I don't want you to get intimidated by this slide either. The takeaway here is that the diagnosis of NTM lung disease involves 3 different things. So patients have to have symptoms, either pulmonary symptoms like cough, usually coughing up mucus, but sometimes it can be a dry cough, being short of breath. Also some systemic symptoms. Fatigue, as I'm sure a lot of you here have experienced, can be one of the more significant symptoms that you have. Sometimes weight loss or a loss of appetite leading to weight loss, night sweats. You do have to have some changes either on your chest x-ray or your CT scan. Typically, we're diagnosing this with symptoms in a CT scan that can look like lots of different things. So there's multiple patterns, shadows that we might see on your scans that either you've come to us with symptoms and we go looking with the CT scan, or maybe you got a CT scan for another reason and people found these patterns and then got worried that you might have an infection. And then we do have to confirm that infection with microbiology. So we have to grow this bacteria in the lab. We really prefer to get the samples from your sputum. That's why I'm sure whoever you've been seeing has been asking you to submit sputum so that we can test it. And you do have to grow the same bacteria at least twice to make the diagnosis. If you can't make sputum, or if there's some you're growing different bacteria, we're not sure which one it is, sometimes you may also undergo a procedure called a bronchoscopy. And from that wash from the bronchoscopy, we may grow the bacteria, and you only have to have 1 sample for that. I mentioned with the stars that some of these bacteria are more likely to cause infections. So sometimes when we grow this bacteria, you're really infected with it. And so it's causing, I tried to make an analogy like a garden. So these can be seeds that land in the soil, and some of them are going to grow and cause weeds and some of them aren't. So if you submit a sputum sample, and I think most places have my chart now, and so you're getting these results back on your phone and getting alerts and emails, and what does this mean? That can be complicated too. Sometimes if you're growing these mycobacteria, it means that you have an infection. Sometimes it can be either a contaminant in the sample, so it grows but it's not there, or it could just be something that's not causing harm. So it's there, we could see it, and it's not causing harm. So this is part of why it's important to make sure that the doctor or the provider that you're seeing is very familiar with this, because there's some of these bacteria that we get pretty worried about, and there's some of these bacteria that you may grow and your provider may tell you, you don't need to worry as much about this one because it's not typically something that causes an infection. Even that, again, I would encourage you to speak with an expert if you can, because some of that can, everyone's body is a little bit different. So when we would consider something a true infection or not is going to vary a little bit person to person. I'm sure a lot of you are asking, what should I do if I've been diagnosed with NTM lung disease? And there's a lot of different answers to this. I have 3 slides on this, but certainly you should talk with your provider about treatment. Those of you who have been on treatment or have talked with your providers about treatment know that treatment's not easy. It's typically a long course of multiple antibiotics. And it's depending on which of these bacteria you grow, that treatment may be different. It may involve some IV antibiotics. It may just be antibiotics that you swallow. So absolutely, you should talk with your provider about whether you need treatment and what that treatment would look like. These infections are pretty complicated. And so if at all possible from a financial standpoint or from a travel standpoint, you should see if you can be referred to an NTM or bronchiectasis care center. On the first or second slide, Dr. Flume showed you in this area, the care centers that there are. There are resources through the Bronchiectasis and NTM Association, as well as NTM-IR that can tell you providers and doctors, hopefully near you in the region, who have expertise on this. And if it's at all possible, I would encourage you to see if you can see someone in one of these centers, because the treatment is complicated and it's best if you have an expert, someone who has a lot of familiarity with treating this. It's also a type of chronic illness. Like I said, treating it typically is at a minimum 12 months of antibiotics. And I'm sure a lot of you have experienced that the antibiotics can go a lot longer than that. And so joining a support group, either a local in-person support group, which hopefully with this care center, we're going to get even more, but also potentially a virtual support group. And again, through the Bronchiectasis and NTM Association, there are virtual support groups that can help you understand what other people have gone through and that you're not alone in this. The other things, these ones aren't necessarily specific just to NTM, but when you have bronchiectasis and you have non-tuberculous mycobacteria, trying to avoid any further damage to your lungs is very important. So I would encourage you to get vaccinated against all of the other pulmonary infections that can affect your lungs. It's not that these infections would cause NTM, but if you already have one infection going on in your lungs and then you get a pneumonia, or you get the flu, or you get RSV, or you get COVID, that can make everything worse. Avoiding tobacco exposure. So if you are smoking now, talking with your provider about resources to stop smoking, because there are resources out there that we can help you with. And if possible, avoiding secondhand smoke exposure as well. Exercise can really help with your lung health. And I think all of us in this room agree that the key to really treating NTM is treating the bronchiectasis and the underlying lung disease, not just antibiotics. And so a huge part of that is airway clearance therapy, which I think we'll talk about a little bit more in other parts of this presentation. I probably don't have to say this to you because you're on this webinar, so you're doing exactly this, but I think educating yourself is really important here. Again, unfortunately, there's a lot of providers who don't know much about these infections because they're really hard and they're really complicated. And so doing everything that you can to really educate yourself and advocate for yourself is one of the best things that you can do. I love it when my patients come to me and they're like, hey, doctor, I was just on this webinar and this patient said their doctor was doing this. Should I do this? Hey, I was reading this study. I have a patient who emails me studies frequently, which I love. I think that's so helpful. So educate yourself and be your own advocate. I wish the system wasn't that you have to advocate for yourself, but at the end of the day, you do. So not just attending webinars like this, but also there's such great resources out there through the Bronchiectasis and NTM Association. It used to be a different website, and if you go to that old website, it will direct you to the new one. But if you're familiar with the other colors on the website, it's changed, but it's the information there is fantastic. You do want to be careful with where you're getting your resources from. I have had some patients who have heard some things on Facebook support groups that maybe weren't exactly what I would recommend. So we know that the Bronchiectasis and NTM Association, as well as NTM-IR, have vetted information that is good, that is true, and has a ton of different resources on there. Similar to what Dr. Swenson was saying, this last part, which is considering making changes at home that may help. I say all of this with a little bit of a grain of salt. I don't necessarily have super strong data that every single one of these, if you stop doing this behavior, that it's going to get rid of the infection or make you not exposed to the infection, or that doing this caused you to get the infection, but they are certainly things that you can consider doing to try to decrease your exposure. At the end of the day, like Dr. Swenson said, unfortunately, there's no way to completely avoid being exposed. And so a lot of this is going to have to do with managing the bronchiectasis and really treating that underlying lung condition, not just the NTM. And that is all I have. Thank you.
Okay. Hi, everyone in the room and out there. My name is Dr. Lauren Sullivan. I'm a bronchiectasis and NTM doc here in Charleston at MUSC. I'm going to be talking a little bit about bronchiectasis, both the diagnosis of bronchiectasis and some risk factors for the disease. So bronchiectasis is a lung condition or a lung disease where the airways get widened. So bronchiectasis, the term literally means widened airways, and these airways are often thickened and scarred. When that happens, as you can see in this picture, there's mucus that builds up in the airways, and that can lead to inflammation. So your body's own immune cells coming into the airways and causing damage, and also a susceptibility to infection. So in normal lungs, there are these tiny little hairs called cilia that line the airways and help move things that we inhale in, as well as mucus and bacteria, other things from the environment, up and out so we can cough them out or swallow them. But in bronchiectasis, the airways get damaged, the cilia don't work as well, those little hairs, and mucus builds up. And then it's kind of this cascade where the mucus is there, that invites in the immune cells from the blood, and then the bacteria that also gets stuck in there, that invites in more immune cells, and that causes more damage to the airways. So the central problem is that the airways are dilated, but then there's this cascade that follows that leads to the susceptibility to infections. So what are the symptoms of bronchiectasis? I think one thing that we often find is that people have been misdiagnosed with other conditions prior to being given the diagnosis of bronchiectasis. And that's because the symptoms can be shared with a lot of other lung conditions. So one thing that is common in people with bronchiectasis is frequent cough. And this cough is often productive with thick mucus that can be yellow or white or green in color. And it can vary in amount, and it can vary based on the time of year or if they have an infection. Some people may also feel breathless and associated with the cough. And we often find that people may have been given a diagnosis of asthma or COPD, even COPD, never having smoked, for example. Another thing that is common is to have been told that you have frequent bronchitis. You get bronchitis, you require antibiotics a few times a year to clear it up. But never actually honed in that it could be bronchiectasis, which is really a structural problem with the lungs. Additionally, there can be other more systemic symptoms, like just being really fatigued, having fevers, chills, and sweats. And additionally, some people will say that they just can't gain weight, or their appetite is low, and they're kind of losing weight and they can't explain why. So how is bronchiectasis diagnosed? You can see here 2 images of a CT scan, which is basically a fancy series of x-rays of the lungs. A traditional chest x-ray, many people have had, but that doesn't really give the resolution we need to see the airways. So typically we need a CT scan to make this diagnosis. And that can show us both the distribution of bronchiectasis, those widened airways, and kind of the extent. So you can see on the left-hand side, that would be a more mild case. And on the right-hand side, that's more advanced with more of the lung involved and more lung damage as a result of bronchiectasis. You may have some other tests done as part of the workup of bronchiectasis, and that may include lung function tests, where we basically check your lung function. It's what it sounds like. Another common thing that we'll do is check the sputum, and that's to identify infections, whether it be with NTMs, like you've heard about already, or other bacteria or fungi. Lastly, you may have some blood tests done, and that is to try to figure out what might be causing the bronchiectasis, which we'll talk more about in a bit. So one question that is asked similar to NTM is bronchiectasis contagious? No, this isn't a lung disease that's passed from person to person. It's unlikely that you're going to pass anything to someone else, but you are more likely to get sick from other people if you have bronchiectasis. So washing your hands and vaccination, as already mentioned, are encouraged. So we'll talk a little bit about what causes bronchiectasis. So one common cause of bronchiectasis is infections. So this could be a prior infection, like a bad pneumonia that causes a local area where the lung is damaged and a more focal area of bronchiectasis. There can also be a more chronic infection, like an NTM infection that causes bronchiectasis, and also kind of certain allergies to fungi in the environment that is sort of an infection and sort of an allergic reaction, and that is tested for in the workup of bronchiectasis. There's also genetic causes of bronchiectasis, and I think this is one of the things that we know the least about in our field is, the underlying genetics of this. Cystic fibrosis, which some of you may have heard about or know a family or member or friend with, is the most common inherited cause of bronchiectasis, but there are very likely other genes involved that we just haven't fully discovered and therefore don't have treatments for. We know that there's a role for acid reflux and aspirating, so the contents that are supposed to stay in the stomach or go from the mouth, the oropharynx down into the stomach, going down the wrong pipe, so to speak, and ending up in the lungs. We'll hear a little bit more about that in a dedicated presentation. And there's also an association of inflammatory conditions with bronchiectasis. So, for example, rheumatoid arthritis and inflammatory bowel diseases like ulcerative colitis and Crohn's disease have been associated with bronchiectasis, but the causal relationship isn't fully known. And I say all of this, but 50% of the time, no cause is identified despite workup. And I just want to backtrack by saying, in terms of infections, immunodeficiency, so low antibody levels is another thing that we check for because that can lead to bronchiectasis. So what are the treatments for bronchiectasis? And we'll hear about this throughout the day, so I'm going to talk about a few of them. In general, there's sort of three pillars that we think about. The first is airway clearance. The second is treating infections. And the third is managing the inflammation associated with bronchiectasis. So you hear about the treating infections and managing inflammation later, and I'm just going to talk a bit about airway clearance. So airway clearance just simply is a way to get that mucus that's stuck down in there up and out of the lungs. It's a way to help your lungs clean themselves more effectively, and we with a variety of different methods. So there are manual techniques, devices to help us, as well as inhaled medications. Again, with the goal of moving that mucus out of the more distal airways into the central airways so that you can actually cough it out. So some manual techniques, the first I would say is exercise. Anything that gets your heart pumping, your deep breathing, that mobilizes those areas of the lung that may be more distal, and anything that that does that and gets you really breathing more heavily is great. There's also directed coughing techniques, as well as something called postural drainage, using different positioning to try to optimize the drainage and the outflow of mucus from the lung. And then there's manual chest physiotherapy, someone actually kind of beating on your chest. And I should say that, a respiratory therapist is an expert in these techniques and some of the other ones that we'll talk about. So I think advocating to meet with one as part of your care is a super important aspect of managing bronchiectasis. So we talked about manual techniques, including exercise. There's also some devices that can help with this. Some of you may have used some of these before. The two on the outside are both called OPEP devices. So that's oscillating positive expiratory pressure device. And that's just a fancy term for you exhale into this device and it creates some resistance, usually with a little valve or a ball. And that sends some vibrations back down into the airways to also help mobilize the mucus. Additionally, your provider may recommend a vest for you, which uses oscillation on the outside of the chest to try to move mucus around and mobilize things. Lastly, we sometimes use inhaled medications. So inhaled salt water, which you may also hear called saline. So if you've ever had to get a bag of fluids, say in the emergency room, you were dehydrated, that is just salt water and it's 0.9%. So what we often recommend is 3%. So it's a concentrated salt solution that you inhale. And the goal with that is to hydrate the mucus, make it less sticky on the airways, and along with those either devices or manual techniques, allow it to move from those distal airways up and out. There's also, in some circumstances, indication for chronic inhaled antibiotics, as well as inhalers like albuterol to try to keep the airways more open. So that's just a brief overview. I think it's already been shared, but there's great educational resources online, ntminfo.org, bronchiectasisinfo.org, and then the Bronchiectasis and NTM Association, where all these resources are readily available. So turn it over to the next speaker. Thank you.
Good afternoon, everyone, and thank you, Dr. Flume, for organizing this meeting and this webinar. My name is Anas Hadeh. I'm the co-director of the Bronchiectasis and NTM Center at Cleveland Clinic, Florida. I'm going to be talking about bronchiectasis exacerbation management. So you probably have heard this term before, exacerbation. What are exacerbation and why do they matter? Exacerbation are flare-ups of your pre-existing chronic symptoms or having brand new symptoms that you've never had before. And why do they matter? Because they can harm your lung health and can affect your quality of life. So the goal here is to recognize, manage, and prevent these exacerbations to stay healthy. So how can you recognize that you are experiencing an exacerbation? So number one, you're going to see a change in your symptoms. So you might have worsening cough in terms of its frequency. You might have a change in your sputum volume, quality. The sputum might become thicker, and also might experience change in sputum color. Your yellow sputum becomes green, the green becomes brown, and sometimes you might have a bloody sputum. Another important symptom is having increased shortness of breath. Sometimes you might hear yourself wheezing, and finally, fatigue. Most of the times, those symptoms can happen over days, 2 to 3 days, but sometimes might happen quite suddenly. So what can trigger exacerbation is a variety of factors. Some of them are infection, pollution. I'm going to discuss that in detail. So the triggers of exacerbation are grouped into 2 subcategories. Number one, external. So these are things that you might have a new irritant or new infection. Big example here is having a bacterial infection, such as infection with Pseudomonas. Another big important trigger of exacerbation is viral infection. If there's something we learned from the pandemic, is those patients who were masking and were social distancing had actually a much less exacerbation rate during the pandemic. A third important factor is air pollution. So whenever I practice in Florida, whenever there's Everglades fires, I see increased frequency of patients who are having flare-ups. Number 4 are aero allergens. So these are the external factors. Internal factors, these are, if you have another airway disease or another systemic disease that causes inflammation in your body. Example, if you have asthma or COPD, you tend to have more exacerbation. We're going to talk in details about GERD or acid reflux and chronic aspiration as an important trigger of airway inflammation and exacerbation. What we know, whether you have an external trigger, an internal trigger, your lung ecosystem, if you may, gets out of balance, making exacerbations more likely. Next question you need to ask yourself, are you a frequent exacerbator? And we do define a frequent exacerbator as having 3 or more exacerbation per year. It's typically linked to having tougher to treat or harder to treat bacteria like Pseudomonas. It's also linked to having lower lung function. And this is, we have here a vicious cycle because exacerbation by themselves will lower your lung function. And if you have low lung functioning, you are more frequently exacerbating. So this is very important. How can we break that vicious cycle? And as I mentioned earlier, having another airway disease such as COPD or asthma gonna increase your risk. What are those risks? So number one, worse quality of life, faster lung decline, and higher chance of hospital stays. I'm going to show you here a graph highlighting my point. This is comparing 2 different patients. So this is on the y-axis, your lung function, and on the x-axis this time. And the line on top, highlight a patient who have maybe less frequent exacerbation that are mild. On the other hand, the line on the bottom is another patient who have more frequent exacerbation and more severe exacerbation. And you can see here the slope of those 2 lines are quite different, with the patient who are having more frequent exacerbation, more severe exacerbation, have a much faster rate of declines. Furthermore, I want to highlight here, if we zoom in on those graphs, is when you get an exacerbation, we give you antibiotic, we treat you, you increase your airway clearance therapy, but typically you may not go back and reach that lung function prior to that exacerbation. This is why it's important to prevent those. So how serious is my exacerbation? When I get a call, or if your provider gets a call about an acute exacerbation, we go through that mental exercise. Are we dealing with a mild exacerbation that could be managed at home with maybe oral antibiotic or sometimes just extra airway clearance therapy? Or are we dealing with a severe exacerbation that may require hospitalization because you're having, a severe shortness of breath, or you might have been having heavy bleeding, or you might have fever. And by the way, fever is a very late sign for an exacerbation. If you are having fever, that means you probably have been neglecting to share your symptoms with your provider for at least a week or 2. So in order to answer that question, we try to answer your question over the phone, but sometimes we might ask you to come in to see us in the clinic, to go to urgent care, and sometimes we might ask you to go to the ER. And because sometimes we might need extra data points, such as blood work to assess infection signs. Definitely viral testing is very important, whether you do that at home or in a facility setting, because if we identify that you have a viral infection as the reason of your exacerbation, that will change our management. We can give you antiviral, for example, for influenza or COVID. We might ask you to collect a brand new sputum. So most of the time, if you are keeping up with your visit with your provider, we collect sputum so to save it for a rainy day when you are having exacerbation, so we don't have to guess in terms of what antibiotic to give you. But sometimes we might ask you to give us another sputum during an exacerbation. And sometimes, quite frankly, I might ask some patient to come in to get some imaging, because those symptoms of cough and shortness of breath, they might not be specific to an exacerbation. So sometimes a patient with bronchiectasis might have some other reasons for their symptoms. Example, pneumonia, sometimes a blood clot, and I might need some sort of imaging to be able to tell what's going on. And finally, we need to assess your oxygen level and assess whether you need supplemental oxygen. So what you can do during an exacerbation is very, very important. And we heard earlier from my colleagues about the importance of airway clearance therapy. In fact, I have some patient who might have called early in an exacerbation, and within a few days of aggressive chest physiotherapy, for example, or doubling up or tripling up on what they do in terms of their nebulization for bronchodilator or mucolytics, able to nip it in the bud and avoid going to that next step. But sometimes we need to give antibiotics. In fact, majority of time we resort to antibiotics to help us, unless we have a very specific reason for an exacerbation. So typically prescribe antibiotic that you might take often for 14 days, sometimes longer than 14 days, and rarely we might use it for a shorter duration. During an extubation, it's very important to keep up with your hydration. So stay hydrated, drink plenty of fluids to help thin your mucus. And another very, very important point I'd like to highlight here is self-monitor, especially on day 2, day 3, day 4 of an exacerbation. Are we really going on the right path here, or we need to escalate therapy? And there's a lot of tools that can help you to track your symptoms. One of the tools I like to do, I'll show you in a slide later, is the best tool, which can track your symptoms on a daily basis. The next slide I really love to show if any lecture on bronchiectasis is to highlight how airway clearance therapy works. So this is I call it my plastic surgeon slide. I showed you before and after. This is a CAT scan of one of my patients who has bronchiectasis before airway clearance therapy. And this particular patient is a pro, and this is his CAT scan. As you can see, the airway are much cleaner, and all those mucus block that are in white are now gone. So airway clearance therapy is very, very important. This is the best bronchiectasis exacerbation and symptom tool, and there's plenty actually on the association website. You can find other tools as well to track your symptoms, because again, we need to know by day 2, 3, or 4, are we getting better? Is that shortness of breath is improving? Is the cough is getting better? You might have some improvement in one of those domains, but sometimes multiple domains, because if not, we need to escalate care. And this is when you need to go back and call your doctor, especially if you're not getting better, especially if you are experiencing some of the alarming symptoms, for example, severe shortness of breath, now you're coughing up blood, as I mentioned, fever, and or if you're having mental states change, like disorientation. So this is when you have to reach out to your doctor, tell them, hey, things are not going the right path, and we need to escalate. So typically at this point, this is when we might ask you to come to the hospital or use intravenous antibiotic as an outpatient, but that's the call to escalate therapy. So remember to take action quickly with prompt treatment can avert more severe consequences. Recovery. So you will recover, but it might take some time. So it will take somewhere between 2 to 5 weeks. Sometimes some patients might have lingering symptoms. And it's very important after you recover from an exacerbation to recognize that exacerbation will have increased chance of cardiac events. And also, if you had an exacerbation, you are at an increased risk for that next year to have another one. So the goal actually is to work with your doctor to stabilize your lungs and avoid complications. So how can we prevent exacerbation, or how can you stay ahead of exacerbations? So you need to follow up the treatment that were prescribed by your provider. So whatever your provider recommends based on your disease, you need to adhere to your airway clearance therapy, your bronchodilator, your mucolytics. Certain frequent exacerbator might be prescribed antibiotics in the form of macrolides for its anti-inflammatory property, but sometimes we might use inhaled antibiotics. So whatever your doctors prescribe for you, you need to adhere to that. Keep up with your regular airway clearance therapy. Very, very, very important. Try to identify your triggers and try to avoid them, especially avoiding smoke, dust, air pollution, and obviously avoiding sick contacts. Nutrition. Very, very important to keep up with good nutrition that supports your health and overall well-being. Stay active through exercise. And my colleague earlier mentioned the important role of vaccination for especially respiratory viruses that are recommended by your provider because it will reduce your infection risk. So in summary, we want you to take control of your bronchiectasis, be aware of your triggers, and recognize early warning signs and take initiatives, adhere to your chronic treatment plan, and collaborate with your health care professionals. And stick around because there's, especially in this webinar, especially last session, there's exciting new research that can help you with exacerbation reduction that are on the horizon. And with that, I would like to move into our next speaker, next topic. Thank you.
Good afternoon, everyone. Thanks for your time and attention. Today, I'm going to be talking about adverse drug reactions, medication intolerance. I work with Dr. Haday at Cleveland Clinic, Florida, as co-director of our Bronchiectasis Center, and I also serve as the division chair for infectious disease. So treatment regimens you've heard about from my colleagues already today. Typically, it will include 2 to 5 drugs. It's very much dependent upon the species. You heard there's over 200 various types of NTM species out there, and the drugs that we pick is very much dependent upon the species and even subspecies. Further to that, it's also dependent upon the susceptibility testing that we have back. And therapy is highly individualized. Why? Because we need to consider our patients' underlying medication intolerances. We have to consider things like what we call polypharmacy. Often patients are taking multiple other medications at one time. And so I'm not going to get into the nuances of very specific treatment regimens, but rather just a broad and general overview. These therapies can include either a combination of IV and oral, or only oral, or IV oral inhaled. So there's lots of different combinations. And for some subspecies like Mycobacterium abscessus, as an example, we'll start with something called an induction phase, which is very intense antibiotics for a couple of months, followed by a step down or consolidation period. Most of the drugs that we use are subject to prescription drug coverage. That can sometimes be a challenge. Many of the medications that we use are still technically off-label for use, so that can sometimes present barriers to care. But we work very hard with our patients to ensure that they have the best possible regimen available to them, understanding some of those nuances. The goals of therapy is to be at least culture negative for 12 months. So the vast majority of patients are on therapy for longer than 12 months. When we start treatment, we'll check sputum cultures once a month. That's always our goal, to look for that negative sputum culture before we sort of declare victory and say, okay, our 12-month clock starts now. Toxicities are usually dependent on the duration. So the longer we're on treatment, the more likely we're going to have toxicities from our medications. But to that point, sometimes they're also dependent upon the dose. When we start a regimen, treatment monitoring usually includes a combination of several different things. Blood work is standard for everyone. Most patients we will ask to have hearing testing done, not only at baseline, but also throughout therapy. And that is primarily because 2 of the main medications that we use in our treatment, which is the macrolide class and the aminoglycoside class, can affect hearing. Doing a baseline hearing test is extremely important because we need to know where we're starting. Sometimes changes in hearing can be very subtle. Patients may not overtly notice something has changed, but catching that early and intervening or pivoting the strategy is very important for good clinical outcomes. Something else we also do is baseline eye tests, particularly for ethambutol, if that's being used, which is part of our MAC regimens. So again, we would do baseline, and then we would usually check every 2 to 3 months afterwards. We just talked a little bit about sputum. So the goal is always to do sputum cultures. We strive for monthly. Many patients will tell us after a few months of therapy that they're not making sputum anymore. And that's actually a positive sign because it means our treatment is working. So we strive for that. For folks who have a difficult time producing sputum, we'll often ask to try to collect that specimen after you do your hypertonic saline and your chest therapy, which is when we will typically get our highest quality specimen. So depending upon the study that you read, adverse events are reported in up to 70% of patients. That sounds really scary. And to be honest with you, I don't personally see that in my practice. So I advise caution, but that is the data. I think that it's less common when we use intermittent therapy. So some regimens will be Monday, Wednesday, Friday rather than daily. It's extremely difficult to predict or know who is going to tolerate therapy very well and who may have challenges and bumps in the road. We're all unique individual beings, and I tell patients in the clinic, you never really know something unless you try. So we have to try and see what happens, and then we go from there. The vast majority of people who do have medication intolerance, when we take oral or IV regimens, they're usually GI associated, so nausea, diarrhea, something. Some people can have changes in their liver function tests. For those who are taking macrolides or aminoglycosides, it can be ringing in the ears. tremors, a change in hearing, or eye changes, particularly with ethambutol. So I included the most common medications that we use, but by no means is this a comprehensive list of antibiotics that we use for NTM lung disease, but I wanted to focus on the ones that are most commonly deployed in clinical practice. So inhaled amikacin, which many folks now know as Arikayce being the most common drug, does frequently cause a change in voice or what we call laryngitis. So most folks will describe that as a deepening or a more husky part of the voice. And then some folks will have bronchospasm. And I have a slide in a couple of slides from now to talk about strategies. So we talked about routine hearing tests, which is something we use to mitigate, meaning we need to follow folks when they're on therapy to make sure that they're not having any unanticipated outcomes. IV amikacin is generally used in the very beginning. So we use that for our strong induction therapy for patients who have more severe disease. It can be toxic to the kidneys, so very close laboratory monitoring every week is done, and we only use this medication for a short period of time. So guideline-based therapy is typically 8 to 12 weeks. We stop the IV amikacin and then move on to a consolidation regimen. But as part of that, we will continue to monitor not only kidney function, but then also hearing tests. And of course, we would stop therapy if anywhere along that way we started to see signs of toxicity. For the macrolide class, which is generally azithromycin, it does include clarithromycin, but in the US, we really use azithromycin the most. It's better tolerated. GI upset is the most common side effect. We do check EKG, which is looking at the heart rhythm, and then also for cross-drug reactions while on medication. And then ethambutol I touched on. So I always say E for eye is the easiest way to remember this for patients. So ethambutol can cause inflammation in the optic nerve. It's really quite rare. I've only seen a handful of cases myself. It's hard to know in the literature really what the exact percentage is. The risk seems to be variable. It also seems to be dependent upon the dose and the frequency for most patients. When it does happen, we will stop therapy altogether and then possibly consider reintroduction if it is required, depending upon underlying causes of infection and risk factors and so forth. So rifampin is commonly used for MAC infection. It discolors bodily fluids for everyone. That's virtually 100%. I always tell folks, you know, you have really, really bright yellow or orange pee. This is normal. Don't worry. No cause for panic. And then we'll monitor through looking at routine blood work. Clofazimine is used for some of our Mycobacterium abscessus isolates and others. The most common side effect with systemic use is dry skin, and it can cause darkening or discoloration. It really depends upon someone's underlying skin tone. So it can be sort of, I'm Caucasian, for example, so it would be sort of like a dark tan or fake tan look, if you will. So we tell folks to avoid sun exposure, use emollients if you have really dry skin, and then we monitor EKGs along the way. Omadacycline is emerging in this space as being a really potentially exciting drug. We'll see as time goes on with more and more data that comes out. The primary thing it can do is cause GI upset, and that can be mitigated by taking crackers or a small snack, something of that nature, with the medication, which helps sort of calm and settle the stomach. And then linezolid can cause changes in the white blood cell count. It can cause it to drop. And then long-term use can lead to other things, but not to, you know, scare or anything like that to anyone. These are all conversations that we have with our patients when we start therapy, because they are real risks. But all that being said, despite being transparent and open in our conversations with patients as we start therapy, I think it's really important for everyone to understand that the likelihood of having these types of significant adverse outcomes is really quite small. And even when they do happen, there's always things that we can do to make things better. So the way that I like to divide this out is that we have provider-driven strategies, things your healthcare provider can do for you if you are having challenges with your medication regimen. And then there's patient-driven strategies, things that you can do to help yourself along the way and tolerate things better. So from a provider perspective, when challenges arise, some of the things that we think about doing are either stopping therapy altogether and then doing graded reintroduction. Some folks will actually do graded introduction of therapy from the very beginning. What that means is starting one drug at a time and then adding them, say, every 5 to 7 days. There's no right or wrong way of doing things or answering the question. I think it's a provider to patient discussion in terms of what they're most comfortable with. But if we interrupt therapy, we'll usually restart one agent at a time, particularly if it's not clear to us exactly which one is causing the problem, to better pin down exactly what the issue is and then come up with a better solution. Another option is to lower treatment doses. So if we, for example, start out with azithromycin 500 milligrams, we can always lower the dose to 250, things like that. We can step down from daily to 3 times weekly therapy, stop a suspected agent altogether, move to a different drug class, or in the example of IV amikacin, just stop it and then maybe make a switch to Arikayce if needed. For patient-driven strategies, what we recommend are several things, and these are really important for all patients to know. One is to avoid extra supplements, especially vitamins. Actually, some of the medications that we prescribe do interfere with vitamins in terms of adequate drug absorption. Also to avoid non-essential alternative medications, so over-the-counter herbal supplements, bodybuilding powder, all of those things, surprisingly, all of these things can compound each other and then make the risk of having a reaction or an adverse reaction higher. We also will recommend not to drink. A lot of the medications that we use are metabolized by the liver, so when you drink on top of that, it just puts more stress on the metabolism through the liver, so we recommend no drinking at all. Taking medications before bedtime seems to be the best strategy for most people. It does tend to ease the GI and nausea complaints that some folks will have. But all that being said, it's not for everyone. Some folks actually feel better if they space their medications out throughout the day. So as a patient, as a provider, I instruct my patients to use the medications at different times if they're having some tolerability challenges, and find the strategy that works best for them. Because ultimately, the strategy that works best for you is going to keep you engaged and want to continue on your therapy. Even for those medications where they say you should not take anything whatsoever with the medication, it is permissible to take a small snack. So for example, omadacycline can cause GI upset for some. Taking it with a few crackers is actually okay. And then also talk to your provider. If you're having challenges or you're having tolerability issues, talk to your provider and come up with a solution that will keep you on track. And be hopeful. Don't lose hope. Challenges, we all have challenges. It doesn't matter whether in life or otherwise. Be hopeful and understand that this is a process that's going to take time and commitment, but you will get better. So inhaled antibiotic side effects, this is primarily Arikayce. We talked about how you can have hoarseness or laryngitis or something of that nature. Very common side effects are coughing and making more sputum. Rare side effects is bleeding, so hemoptysis, so you do the Arikayce and then you start having bleeding right after. Hearing loss is very rare as well, but we talked about how we check hearing tests throughout therapy. And then allergic reactions. So if you have severe symptoms such as coughing up blood, you stop right away and call your doctor. If there's no improvement, sometimes you'll be instructed to hold the medication for several days, wait for the bleeding to stop, and then sometimes we will consider a re-challenge depending on the patient. That is a provider to patient discussion. The good news is that all of these things can be mitigated with simple strategies. So even if there's an unanticipated side effect with inhaled therapy, 8 out of 10 people can successfully have mitigation strategies put into place to be able to tolerate their regimen. So after using the inhaled antibiotic, make sure you rinse your mouth out with warm water or regular water. If you are using a bronchodilator like albuterol, it's best to do it prior to doing your inhaled antibiotic. And if you're doing airway clearance techniques, it also helps to do that before, because you clear out all of those mucus and secretions. And then as you inhale the antibiotic, it allows better penetration into the area of the lungs. All right, and those are my references. Thank you so much. I'm going to turn it over to our next speaker.
Hello, everyone. My name is Christina Mangora, and I'm one of the pulmonologists here at MUSC who works in our NTM, bronchiectasis, and cystic fibrosis clinics. And I'm here to talk about reflux, which has come up multiple times during our talks today. So we're going to talk about how this can relate to bronchiectasis and risk for infection as well. So during today's talk, I want to help to define two different types of reflux, which you may have heard about. These are gastroesophageal reflux and laryngopharyngeal reflux. I also would like to identify some common symptoms of each of these entities and then describe the testing and treatment strategies. In doing this, I'm going to walk you through a patient case so that you can understand why and how we as providers may be asking some questions and how we get to the diagnosis. So as I said, we'll begin with a case. So we had a 67-year-old woman who was referred to our clinic for evaluation of chronic cough and abnormal chest imaging, which demonstrated bronchiectasis. Relevant parts of her history included that she was a lifelong non-smoker. She did have a remote history of sinus surgery, though this did not have any impact on her cough. Previously, she was taking an ACE inhibitor, which is an antihypertensive or blood pressure medication, which can be associated with cough. However, again, this was discontinued and had no impact on the cough. Previously, she had undergone evaluation for the possibility of reflux with an endoscopy or EGD. And this was reportedly negative. And she was treated with a PPI or an acid suppressive medicine, which again had no impact on cough. Sputum cultures were collected, and these grew two different types of common bacteria called Moraxella and Haemophilus. Unfortunately, the patient continued with cough, so further evaluation was pursued with a bronchoscopy, which is another way to get sputum samples, which was talked about today. And what was found on this was that the bronchoscopy evaluation of the airways was normal. And we did not see any significant findings to suggest active infection in terms of doing the bronchoscopy. When looking at the imaging, we can see that the patient does have mild bronchiectasis. And we can see that while it's mild, we see a significant portion of this more so in the lower portions of the lung. And sometimes when we as providers are reviewing your imaging and we see different distributions of bronchiectasis, as was mentioned earlier, it can help us allude to reasons why we may think there's a particular reason for bronchiectasis. And particularly when we see changes that are more confined to the lower portions of the lung, reflux is something that does come to the top of our minds as something we need to be further evaluated. So again, we've talked a lot about reflux. So what is the definition? So gastroesophageal reflux disease, or GERD, is defined as a condition which develops when reflux of stomach contents causes troublesome symptoms and/or complications. So what you can see here in the pictures is when we have we have a stomach going into the esophagus, and when we have essentially a normal area, all of the contents of our stomachs will stay in the stomach, and the bottom part of the esophagus will stay closed. When we're having reflux, what happens is these contents in the stomach are going to flow upwards into the esophagus. This can then cause increased symptoms, and we're going to go and talk about what the different symptoms and syndromes of reflux are. So again, talking about reflux, we talked about having different syndromes of it. If we have reflux that is primarily through the esophagus, or syndromes and symptoms that are going to come and not be associated specifically with the esophagus. So when we talk about esophageal reflux and esophageal syndromes, typically the symptoms that we're thinking about are going to be kind of that typical heartburn. So you're going to have the pain in the chest. You're going to potentially, maybe be even regurgitating food or feeling that there is a sense of food coming back up. When those are symptoms that you may feel with that typical esophageal reflux syndrome. When we look at esophageal injury, there can be things called esophagitis or inflammation of the esophagus tissue itself. Longstanding reflux can also cause other abnormalities in the esophagus, which can be strictures or small areas where the esophagus may narrow. Some people may be familiar with needing to have procedures to dilate or open these areas of narrowing to help with swallowing. We also can see other further complications of reflux that lead to abnormalities within the esophageal tissue that can be seen on biopsies as well. When we're looking at extraesophageal syndromes or syndromes that occur outside of the esophagus, we can see additional symptoms, and these may come in the form of cough, laryngitis, or inflammation of the upper airway, asthma, or even changes to the teeth, where you can have some dental erosion. Common symptoms of reflux, again, we talked about some of these. Heartburn is really the thing that everybody comes to mind, and many times you may, when we ask in clinic, do you have reflux? You may say, no, I don't have heartburn. But again, there's a lot of other symptoms that may come with this. So things like regurgitation of food, dysphagia or difficulty with swallowing, also can be some pain with swallowing. You may have chest pain. You may have nausea, bloating, sore throat, a globus sensation, or a feeling that something is stuck either high in the throat or lower throughout the throat, difficulty with swallowing, and even pain in the stomach area. The point of all this, however, is just to know that when we talk about reflux, we're talking about more than just a typical heartburn. So it is important to think about these other symptoms that you may have. So when we were discussing with this patient, and trying to further explore the possibility of reflux and ask more targeted questions based upon the information that we just reviewed, it turns out that the patient was experiencing a number of symptoms related to reflux that were not necessarily initially kind of going off that flag in their mind. So these were things like intermittent sore throat, episodes of voice hoarseness, a cough, which was reported as feeling high in the chest with need for frequent throat clearing, difficulty swallowing pills, difficulty sleeping because cough was predominant in the nighttime. And we learned that the medication to treat the reflux, which was previously used and felt not to help, was actually stopped prematurely due to some intolerances. So when we hear this, we did become, again, very concerned for the possibility of reflux. Now to talk about the different kind of reflux, laryngopharyngeal reflux. This is reflux that is going to be in the higher aspects of the airway. So this is going to be backflow of stomach contents into the throat. Symptoms associated here are going to, again, be very different from your standard heartburn type symptoms and can include dysphonia or changes in voice. So if you can have a more hoarse or raspy voice, sometimes you may not notice this yourself, but if you have a support person or a partner in clinic, we may ask them, have you noticed if there's been any changes over time? Similar to throat clearing, you may not recognize if this has become part of your day-to-day that this is happening. So we may rely on getting some history from a support person, who may be with you during your appointment. There also can be sensations of things being stuck in the throat, difficulty with swallowing, a persistent cough, or even a sore throat. When reflux is suspected, and we're trying to further evaluate and better characterize what's going on, we may order additional testing or referrals for further evaluation by colleagues outside of our kind of personal clinics. So these may include referrals to an ENT or ear, nose, and throat doctor or a gastroenterologist. Each of these doctors have different tools in which they can investigate and evaluate the upper airways as well as the esophagus itself. So they may perform different procedures, such as a laryngoscopy, which again is looking at the upper part of the airway. We may have you undergo a test called an esophagram, where you would swallow some fluids and then essentially we'll take x-rays as you swallow to physically see, are there changes with your swallowing? Do we see changes in the way the esophagus is functioning in terms of motility? Do we see any of those areas where there may be narrowing? And do we see physical evidence of reflux? So the fluid initially going down, but then returning back up higher. We also may have you be seen by a speech therapist who can evaluate your swallowing function. And sometimes you may be referred for an endoscopy or EGD, which can be performed by a gastroenterology doctor. This is an image from an esophagram. So this is the test that we just discussed. So if you're looking at the panels across your screen, initially what you're seeing is the first picture when the fluid that is being consumed goes directly down the esophagus and into the stomach. And when you're looking at subsequent photos, what's happening is the fluid is going up and down, refluxing up and down the esophagus. And you can see different areas of the esophagus moving as well there. But this is evident that there is reflux in this individual. If we come to the diagnosis of reflux, there's different ways that this can be managed. So there can be pharmacologic management, which would include using different medications, which can be purchased over the counter or prescribed. Two common classes of these medications will be proton pump inhibitors, or PPIs, or H2 blockers, which are a specific type of antihistamine. We also will focus primarily on the institution of non-pharmacologic or lifestyle modifications. So these are different things that you can do in terms of your day-to-day activity or lifestyle to reduce the risk of reflux and try to help to control it without needing to add medicines to your kind of daily regimen. And these can actually be quite impactful. Major things that we comment on are limiting caffeine intake. So it may not be unusual for your provider to be asking, how much coffee do you drink? How much sodas, pops, carbonated beverages are you drinking? These can certainly exacerbate reflux. We also recommend limiting alcohol consumption, as this also can exacerbate reflux. Having smaller meals and making sure you do not eat close to bedtime. Recommending that you remain upright after meals. And sleeping with the head of the bed elevated. There's different ways that you can achieve this last sleep-related effort. So some people can have the fancy beds where you can specify exactly the angle that you would like your head to be at. You also can have additional prop-ups with pillows, or there are wedge pillows that can be purchased and used. And when the thought of doing this is that you can have gravity working with you instead of against you to make sure that your reflux is controlled, or we're not going to see stomach contents coming up overnight into the upper airway, or potentially even being aspirated into the lung. Because as you can recall from earlier during today's session, we did talk about reflux and aspiration being risks and mechanisms for introducing infection into the lungs. If there are symptoms that persist despite going on these particular interventions, there is additional testing and treatments that can be considered. These typically will be instituted either by an ENT or a gastroenterology physician, but there are different evaluations and medications that we can use. Some of the medications that are listed under the treatment particularly are there to kind of work with the motility and musculature of the esophagus to try to work with the muscles itself to prevent reflux and reduce symptoms. And in individuals who have something called a hiatal hernia, or part of the stomach coming up into the chest, there are surgical procedures that could be done for those individuals as well. Of course, requiring consultation, typically with a thoracic surgeon, with a lot of different things coming into play to ensure that there's appropriate candidacy for surgery. So some take-home points for everyone listening is that there really is a method to the way we question. So while you're sitting here and you may come to see us because of an abnormal CT scan of your chest or because you're coughing and we're asking you about caffeine and reflux, and you're like, I'm gonna walk into a GI doctor's office. There is a reason why we do this, because there is a lot of interaction between the lung and other organ systems. And even if you come in and you say, I do not have typical heartburn, it does not rule out the fact that you can have reflux. Simple changes are very impactful. So those lifestyle modifications are number 1, 2, and 3 of things that we do recommend you do to reduce the impacts of reflux and reducing symptoms and infection risk. And as always, our goal is to work to have you feeling your best. And that is the end of my slides, and we will now move over to talk about mental health.
Hi, I'm Ken Olivier from the University of North Carolina at Chapel Hill. And it's my pleasure to talk to you today about mental health. Full disclosure, I am a pulmonologist, a lung doctor, and not a mental health professional. But what I'd like to do is talk to you a little bit about the importance of mental health, both in bronchiectasis and NTM, and some of the research that's been done looking at relationships between particularly anxiety and depression and disease manifestations. So I have this divided into sort of 2 sections, work that's been done on the association of anxiety and depression and bronchiectasis, and work done on those relationships in NTM. With regard to bronchiectasis, it's a disease, as you've heard, that's associated with infections, lower lung function. We know that there are chronic respiratory symptoms that can be quite distressing. It's been associated with worsening health-related quality of life, which is something that can be measured in research studies. And the question is, what about increased anxiety and depression as part of the disease course? This has been looked at in the past in a published paper in 2013 that I referenced at the bottom. And this study had as aims to measure symptoms of depression and anxiety in patients with bronchiectasis. They utilized 2 different standardized scoring systems or questionnaires. And they also evaluated the relationship of health outcomes and health-related quality of life to the occurrence of anxiety and depression. This study recruited 93 patients with bronchiectasis. And of those, 38% had elevated anxiety scores and 20% had elevated depression scores. When they looked at the relationship between those with anxiety and depression or depression, those symptoms were associated with things like increased age. So the older the patient, the more likely they were to have associated anxiety and depression. The more frequent patients had exacerbations, and we've heard earlier about the importance of exacerbations and how those are diagnosed and managed. Those patients were more likely to have an association with anxiety. And there was also an association with worsened health-related quality of life, the impact that the disease itself has on quality of life. With regard to NTM, this is an area that my group has been interested in, and this arose from a patient-centered research priorities conference that was held at Oregon Health Sciences University in 2015. This was an initiative that was funded by the federal government through the Patient-Centered Outcomes Initiative to look at involving the patients in the research direction and in the design of research studies. This group had a patient-focused panel and then several people from academics, from industry, people that make treatments for many of the diseases, and then leaders from patient advocacy organizations such as the Cystic Fibrosis Foundation, the COPD Foundation, and NTM Info and Research. And we heard a lot of input and feedback from patients during this conference. We realized that NTM is a lung infection, chronic disease requiring long-term therapy that can cause or amplify negative emotions. And we heard a lot of feedback from patients about that. We tried to understand what the primary concerns of the patients were in this regard. And they were particularly concerned about anxiety and depression, and especially the effects of mental health challenges on things like medication adherence, particularly the complex treatment regimens that you've heard about for NTM, and on their quality of life. This conference reported and was published priorities, research priorities in a variety of areas. And the number one quality of life priority was to reduce the impact on patients of anxiety and depression. We then formulated next steps about how to approach that, and these included evaluating anxiety and depression after the diagnosis and during treatment of NTM, and assessing the association between anxiety, depression, and adherence to NTM treatment regimens. So we undertook a study at my former institution at the intramural program of the National Heart, Lung, and Blood Institute in Bethesda to assess the prevalence and clinical characteristics of anxiety and depression in patients with NTM and bronchiectasis. So this was done at a single center. It was a cross-sectional study, meaning it was done at one point in time when the patient was seen in our clinic. Our goals were to describe the prevalence of anxiety and depression and the association of with pulmonary disease severity. For methods, when the patients came into the clinic, they were asked to complete 2 screening questionnaires. There was a total of 16 questions between the 2 instruments. One was called the GAD-7, which is a very commonly used generalized anxiety disorder screening tool. And the other was the PHQ-9, again, a very commonly used tool for major depressive disorder. We did testing ahead of this study to see kind of what the impact of filling these questionnaires out would be. And on average, it took less than 10 minutes to complete these forms. We then had summary scores from these 2 instruments that were categorized as negative, mild, moderate, and severe. And so if you keep that in mind, in a few slides, I'll talk about the results we got from this and what the action plans were that were associated with these results. But first, let me just tell you a little bit about the results. So this was relatively similar to what had been described in bronchiectasis in general in terms of the occurrence of anxiety and depression. We screened 145 patients. These were patients that were sequentially seen in our clinic. When we analyzed these data, we wanted to exclude patients who had diagnoses of cystic fibrosis or another genetic disease, primary ciliary dyskinesia, and look primarily at patients with bronchiectasis, non-cystic fibrosis bronchiectasis with non-tuberculous mycobacterial infections. We ended up screening 124, analyzing 124 of the patients that were screened. Of those, 20% reported mild to severe anxiety, again, on that scoring scale that I showed you. 28% reported mild to severe depression. Interestingly, we looked at the association with treatment burden, the number of drugs that they were on, whether or not the patients were being treated for NTM. And in this particular study, we saw no association between the NTM drug regimens and elevated anxiety or depression scores. However, and of concern, there were a total of 1 in 3 patients in this series who either had anxiety and or depression, and only over 75% of these patients had been previously undiagnosed or had untreated symptoms. And we looked at this from the standpoint of whether or not the participants had received or were receiving mental health treatment. Only 15 of the 124 patients had either a past or present history of a diagnosis of mental health problems or were seeking help with that. Of the remainder, 75 patients had negative scores on those two screening questionnaires and had no prior history of mental health problems. Of concern, 31 patients who scored mild to severe or one or both of these scores had no prior history of either mental health diagnosis or treatment. Of greater concern is that 3 of those patients had severe depression and had active suicidal thoughts at the time they were screened. And it was those patients that we were most concerned about in the setup of this study to make sure that what we were doing was safe from the patient perspective. So this is a study that was designed to ask about the presence of anxiety and depression. I think many of us in our clinics are, more focused on the disease process itself and not so much about how patients are coping with that. And I hope that that can change because I think both parts are very important. And one of our reasons for doing this study is that we had a couple of patients before we actually looked who, without asking, it was quite clear that they were depressed and that were having active thoughts about suicide, which greatly alarmed us. And at that point, we didn't have a mechanism set up for how to effectively deal with this. And so we set several precautions up when this study was done. One of it was the way the data was collected. So the questionnaires were administered by the nurses that checked the patients in. They were given an iPad that was actually put in a plastic bag for infection control, and they entered their question answers directly onto that iPad. The results of that were immediately transferred into a database called REDCap, which had a signaling mechanism, and those scores were transmitted to all of the members of our team. There were 2 questions on there that had to do with possible suicide thoughts, that if they answered in a certain way on those, we all got an alert either on our pagers or by text messages so that those patients could be immediately helped. And those questions had to do with feeling bad about yourself or thoughts that you've been a failure to yourself or let a family member down. And then if there were active thoughts that they would have suicide feelings related to that. And that system was tested before we implemented the study. It seemed to work well. We had cooperation from our mental health professionals and our consult service, and particularly the social worker on the team, and that she got these messages and was sort of the primary contact that would help us with dealing with this. We had this somewhat complex algorithm set up about how to deal with the scoring. If the scores were in the negative range, less than 5 on the left-hand side, we still paid attention to mental health. They were provided with standardized brochures that had been made and approved by our institutional review board that dealt with anxiety and depression. And we incorporated this in sort of the routine care of the patient during that visit. If they had positive scores, either on the moderate or severe side, this one is for anxiety. I'll show you a similar one for depression. The team taking care of the patient was immediately notified, and in the course of their subsequent visit with either our advanced practice provider or one of the physicians, they were queried in more detail about symptoms, medical history, prior diagnoses and treatment, and then the need for medication. If there was thought to be a need to medication for anxiety in this case, orders were provided, the patient was put in contact with our social worker, and subsequent follow-up was arranged. This was done even more acutely if they were over on the severe side. The algorithm for depression shown here was very similar to that, except if they were in the severe score range, there was immediate attention provided. If you kind of look down the algorithm on the far right, if there was thought to be immediate self-harm, there were measures taken to protect the patient and then to assist with more immediate care rather than releasing them from our clinic with instructions to follow up later. So I think that this kind of brief study highlighted the need to ask questions about anxiety and depression, that we need to do a better job as clinicians of recognizing that, and in working with our mental health programs in concert with all of you as the patients that are being seen, that if those problems are being recognized, that there are provisions to help with that as desired. So in summary, both bronchiectasis and NTM disease are chronic diseases that are associated with a high healthcare burden. They're areas where we're concerned about the impact that might have on your quality of life, about your mental health wellness. Both are associated with a high prevalence of anxiety and depression, and that those symptoms of anxiety and depression can worsen health outcomes and worsen quality of life. And it's just want to stress the importance of seeking appropriate mental health care for signs and symptoms of anxiety and depression. So thank you for this opportunity, and I will now move over to the next speaker.
I thank you all for the opportunity to speak to you today. My name is Marty Solomon. I'm an associate professor of medicine at the University of Alabama at Birmingham in Birmingham, Alabama. And I'm also the director of our adult PCD and bronchiectasis programs there. So I'll be talking about the drug development pipeline. So we're going to switch to a little bit more about therapeutic development and research in that arena. And so I'll talk about three objectives for this talk. First is to understand the clinical trial process. Some of you may have not been involved with clinical research before in clinical trials, so hopefully give you a little bit of insights into that. Then I'll discuss a review of the current therapies in development for bronchiectasis, and then a little bit about the future landscape of clinical trials and where we might be going with some new things. I want to start with a motivating case, and so this is a case that may ring true for some of you on the webinar today, of a 59-year-old female who has a prior history of mycobacterium lung disease. We talked about this a lot today in the previous talks, with a 4-year history of chronic productive cough, shortness of breath, fatigue, and recurrent infections resulting in antibiotic courses and occasional hospitalizations and respiratory failures at that time. You diagnose the patient with bronchiectasis in your clinic, and you begin to devise a treatment strategy. And despite daily nebulization of bronchodilators like albuterol and hypertonic saline plus 3 times a week azithromycin, this patient continues to experience ongoing infective exacerbations and progressive symptoms, which you've heard about a bit today. And so this is may ring true for me, those in the webinar, and it's a thing that we deal with in our clinics a lot and really plagues us to be able to help our patients in those programs. So we're going to talk today about research, because that's where we're going with this, with the world of bronchiectasis. We're trying to make sure we develop the best therapies to help all patients across the disease spectrum and the disease severities. And so what are clinical trial studies? I'm going to start by answering that question. They study lots of different things, new medications or new combinations. You heard about trials about looking at patient-reported outcome measures like the GAD-7, new diagnostic tests, new medical devices, new ways of using existing therapies, either routes or indications, new ways to change behaviors resulting in better health, and new ways to improve quality of life with acute or chronic conditions. And the concept of clinical trials is answering, will they both help us and without hurting us? That's the key kind of metrics for a clinical trial to be successful. In the kind of parlance of definition of a clinical trial, a few things are part of that. One is that human beings are being studied prospectively, which means that you start from a time point and go forward while on this therapy or receiving this intervention. The intervention, of course, is important, and then there's an outcome of interest. That's an effect. You may hear the word efficacy used today or in other discussions about clinical trials, and that means that is there an effect on some aspect of health as a result of taking this therapy? And so when those things come together, that makes a clinical trial. And so we're going to talk about the areas of research going to that, and then we'll have some special discussion about clinical trials in an area of excitement by the next speaker in a few minutes. So there are several phases to clinical trials, and you may be asked to participate in any of these if you're approached by your clinical center. A phase 1 trial is really given mostly to healthy volunteers. In certain instances, it's given to a small number of patients that may have a disease state like bronchiectasis to test the safety in that. But the key here is really understanding how it affects the body, and is it safe, and there'll be adverse events, which means are there reactions to the medication that may limit its safety for patients. So this is all about safety, understanding how the drug works from a safety perspective and how it may work as far as the body clearing the drug or the use of the device. Then we oftentimes go into what's called a phase 2 trial. Phase 2 trials really start giving the treatments to a slightly larger group, with the goal here of determining both early about effect or efficacy of the drug, and then also a lot about safety and how the drug performs in the disease state of interest. In this case, it would be bronchiectasis or maybe NTM, lung disease, or both. A phase 3 trial is what's really referred to as called the pivotal trials. So this will be 1 or 2 or more trials that investigate the drug longer term with more patients, with the idea of really determining if the drug works for the primary and secondary endpoints. So the primary endpoint will be the quality, the health related aspect that needs to be improved in order for the drug to be approved by a approval agency like the Food and Drug Administration. And so really we're looking here with lots of patients to say, is it safe long-term, and is it showing the efficacy we want to by the endpoints we're looking at? And then some people will participate in what we call post-marketing studies, which are known as phase 4 studies, to really have ongoing safety monitoring of people that are taking a drug after its approval by the FDA or other labeling agency like that. And so that's the types of trials that you may be asked to consider participation in by your team. And if you're interested in trials, which we hope you are, and there's lots and lots of trials emerging in the bronchiectasis space now and in upcoming years, we'd ask you to think about ways that you can engage with that. So how can you find out about clinical trials? One is to go to the clinicaltrials.gov website. I've shown a picture of it on the right here. This is a public website that's sponsored by the federal government, and it looks at really what are the available treatment trials across a large spectrum. You can search by disease state, by types of therapy, and that kind of thing. You can also, and should, and I think this is part really of good care, is asking your team about research and the possibility if you can refer to other places if you're interested in a trial, or whether or not you're cited, your clinical team is participating in the trial and can enroll you there. Then there's also COPD Foundation, other disease awareness websites like the PCD Foundation, asthma and COPD, and others that you may be engaged with through support groups that may help you to be aware of what clinical trials are happening. So I think it's really a multi-pronged. You should do your own search. You should engage with patient advocacy groups that affect your disease state, and you should ask your team about what they're participating in research at your site if you're interested in these. And so the reason we're supporting this is because this is how drugs move forward. We have to test the drugs in people with the disease state to show they're effective before they can come to patients for use as therapies. And so now we're going to turn a bit to the next part of the study, which is really where are we at with clinical research, what's been discovered about clinical research in bronchiectasis, and a little bit about where we're going. And that'll be the discussion for the rest of this talk and then the next talk as well. So you heard a bit about the concept of the vicious vortex in bronchiectasis earlier, and this sort of helps us understand the interplay of various aspects of bronchiectasis as a disease. In this concept, we see there's a lot of interaction between several aspects of what's happening in the lungs. That's lung destruction, airway infections, chronic airway inflammation, which we'll talk a bit more, and impaired clearance, what we call mucociliary clearance. And this interplay really causes periods of what can be known as exacerbation, which we'll talk about in a few minutes, and can drive disease progression if not treated. And so almost all of the therapies that will be discussed today, or you may be learning about from your clinical teams, will impact on an aspect or multiple aspects of this kind of vicious vortex concept in the disease state. So thinking about exacerbations, and we're honing in on this because this has become one of the endpoints, the reduction of exacerbations, which is a pivotal aspect of the disease state that we're now targeting for therapeutics. So why are they important? Well, as you may or may not be aware, exacerbations are episodes of advanced inflammation that may or not be precipitated by infection. Oftentimes they are. In these instances, patients tend to have more inflammation, increased plugging or mucus problems, and increased airway and risk for increased lung damage, in this kind of cycle or vortex. And in this circumstances described earlier, you have an imbalance of symptoms that are worsening, and if left untreated, can really become very severe, resulting in hospitalization, risk for respiratory failure, even death in certain instances, and progression of the disease state overall. And so we have learned that these are very pivotal parts of the disease state in general, and treating these are important. And furthermore, a work that's emerged out of especially the European sphere, we've learned that patients defined that have frequent exacerbations really have a very severe progressive phenotype or type of bronchiectasis. And so defining this sort of frequent exacerbator can tell us about patients that may be enrolled in trials that can help us as an endpoint. So that we can target in these trials patients having frequent exacerbations and try to reduce those as one way to show effectiveness of a drug. And so this has really become one of the kind of endpoints that we track. It's the number of exacerbations over the course of a year or a shorter time frame to know if a drug is working for patients in many instances. You'll hear a bit more about that today as we go along. So what you're going to see in this next slide is a little bit of a review initially, and then a pipeline I'll show in several different slides to help you guys. This is a recent article that came out about 8 or 9 months ago from several leaders in the field. Was published in a special issue of one of the key respiratory journals. And what we know is that right now we really don't have a lot of approved drugs for bronchiectasis. We have the use of some certain inhalational or nebulized drugs like aztreonam, colistin, and other inhaled antibiotics, which we use for chronic infections like Pseudomonas. We have the azithromycin, which is called a macrolide antibiotic, which has been shown in older studies to reduce exacerbations. And we have some very generalized mucus clearance therapies like the use of hypertonic saline and the use of mechanical methods to clear mucus from our lungs. Thankfully, as you can see on the left, there's a huge pipeline of new therapies being developed. And I'm not going to go over all those today in the interest of time, but we will hit on some aspects of these so you get an understanding of what this pipeline is looking like. And this pipeline mirrors much of what we talked about with the vicious vortex a few moments ago. So first I'll talk about a little bit about anti-infectives. There has been a long-standing interest in developing therapies, primarily borrowed from the world of cystic fibrosis, where we've had long-standing use of inhalational antibiotics to try to treat chronic infections like Pseudomonas. Many patients that have Pseudomonas infection will have frequent exacerbations and will fit into this kind of severe phenotype or type of bronchiectasis. However, despite a lot of clinical trial development, there really hasn't been an approved anti-infective in bronchiectasis, short of the use of these macrolide or azithromycin type antibiotics for the use of chronic exacerbations or frequent exacerbations. And this includes a recent trial called the PROMISE investigation, which looked at inhalational colistin as the most recent study, which was published, which had mixed results. This has been a lot of the story in bronchiectasis has been we treated infective exacerbations to improve health-related quality of life or to reduce exacerbations, but the studies have been oftentimes mixed in these development programs. So we're still looking for that elusive, consistently effective anti-infective, which we think will be an important aspect of this disease. Whether or not that's going to be inhaled colistin, we don't know yet. It's still sort of the jury's still out on that, but it has completed its kind of phase 3 or pivotal trials for that. Suffice to say, there will be other approaches on anti-infectives that will be in the future. The next slide, I'll mention briefly about some anti-infective general principles of things that are happening in the NTM world. Oftentimes, as shown by the left-hand graph, this is from the CONVERT study, which was led by Dr. Griffith. You guys heard a bit about in one of the talks earlier. He led this trial looking at the use of an inhalational amikacin, which is also known as Arikayce, and this antibiotic can help to reduce the amount of time patients stay consistently positive with Mycobacterium avium complex or MAC lung disease. So as you can imagine, other inhalational or other types of antibiotics are being explored across a pretty broad spectrum, some of which are listed here. Other approaches to treating infections are being looked at, and this both spans the world of Pseudomonas and other types of bacterial infections and the NTM infections like we've talked about, including viruses that target bacteria, known as phage, and repurposing other anti-inflammatories in this state, as well as novel methods of treating bacteria like starving them of certain types of nutrients and that kind of thing. So you may be approached in various centers, depending on what your type of infections are, about anti-infectives in either the NTM or especially the Pseudomonas space, where we have a lot of active research going on in that world. Next, I'm going to turn to thinking about anti-inflammatories, and you're going to hear a lot about that from Dr. McShane in just a few moments about some of the exciting research happening in that space. But just despite that, I want to say that there's a lot of interest in anti-inflammatories. We know that inflammation, specifically certain types of inflammation, can drive exacerbations in patients with bronchiectasis. And so therapies in development include a drug called Bronchiectasis, which you'll hear about from her in just a few minutes, as well as several others which are in earlier phases of development, including a Boehringer compound that also targets a very similar mechanism, and a drug called ensifentrine, which has been approved for COPD for patients with exacerbations, now being studied in a phase 2 trial in non-CF bronchiectasis that's currently enrolling, actually just started enrolling in many sites across the US and the world. So these are exciting movements forward. With the initial work done in Bronchiectasis, which you'll hear about in a few minutes. Now, many other investigations are happening looking at anti-inflammatories, which may have effects on other aspects of that sort of vicious vortex we talked about, but are primarily targeting a mechanism of inflammation as a driver of disease state. Now, I would be remiss not talking about mucus stasis. This is an area of research that's near and dear to my heart. I'm a sort of a mucus biologist of sorts in my other life outside of clinic. And so we think there's a critical unmet need of targeting approaches that address abnormal mucus and impaired mucus clearance. As many of you will know that there are patients suffering with this disease state. It's really a problem that happens and it causes issues with the daily symptomatology. And a slide that I borrowed from Dr. McShane a few years ago, but I still think is accurate. There's a lot of recommendation for therapies we're targeting mucus, both mechanical therapies like chest physiotherapy vests or breathing techniques or other methods, as well as nebulized therapies to help mobilize mucus. But as many of you will be aware, that's ineffective for everyone. So therefore, there's a lot of interest in developing therapies that can target mucus clearance in this disease state. One question we get asked a lot is, what about these awesome CFTR modulators? I've been hearing about the CF patients are getting that are practically curing symptoms of this disease state. Someone may have heard of a drug called Lexicafta or Trikafta, which has been developed for CF. And I can tell you there's a lot of interest in that type of therapy being used to treat mucus abnormalities in non-CF bronchiectasis. It's maybe a condition that's akin to what's happening in cystic fibrosis, which also causes very severe bronchiectasis if not treated with those types of drugs. And so there's a high prevalence of dysfunction of the CFTR protein, we think, in bronchiectasis patients. At least we're learning that and emerging issue. And so the question is, can we exploit aspects of CF as a disease state that's had very effective therapies for many patients and move that over as a therapy that could be effective for some or all patients with bronchiectasis to help mucus clearance and then affect downstream effects like reducing inflammation, other aspects of the disease. And so I'm going to tell you about a couple of design of trials. One is a trial being led by Dr. Swenson and collaborating with us at UAB in our laboratory part, which they're taking patients with non-CF bronchiectasis who have evidence of a bit of a CFTR dysfunction by having a slightly elevated sweat chloride or one copy of a CFTR mutation if they've been genotyped or sequenced. And they're testing them with a month of this drug called Lexicafta, Tezacafta, Ivacafta, or Trikafta to see if it affects mucus clearance and improves health-related quality of life and other symptoms. And also we're testing those drugs then on cells derived from the patients to see if there's in fact a reduction of this dysfunction in the lab. We test in the test tube for these patients as well. So more to come from this. And I think this has motivated many people to think this is really a viable strategy. And we'll learn a lot from this trial and probably will motivate us to test others because these drugs have been so successful for people with cystic fibrosis. We want to extend that benefit to others that may benefit in the future. There is likely other ion channels. So the cystic fibrosis transmembrane regulator protein, or CFTR, is what's called an ion channel. And it really helps to move water in and out of the mucus to help it clear off of the cell surfaces in your lungs, sinuses, and other organs of the body. And so when it's very defective, that causes cystic fibrosis. But others may have dysfunction of this ion channel or other ion channels, which you can see this kind of cartoon, that may interact with the CFTR protein, including sodium channels and other ion channels like the CFTR protein. So I can tell you there's been recent investigation of drugs that block the function of the ENaC channel, that sodium channel on here, as well as upcoming investigations and trials looking at activation of other ion channels like this TMEM16A protein, which will be leading a trial at both UNC and at UAB in upcoming months to look at this activation. So what I can tell you is that this ion channel concept to help move water and clear mucus is very viable across a large spectrum. You may see patients using this, or you may be involved in trials. In addition, we're looking at ways we can make the mucus behave better. So a group of us have helped to develop out of UNC and at UAB, helped to understand the role of a drug called Arena-1, which is the combination of several different medications that can be nebulized. This drug, as you can see from this slide, when administered to cells with people with cystic fibrosis or bronchiectasis, in fact, helps to clear the mucus. So that stuff streaking across the cells in that middle graph, in that middle video, is the mucus being moved much better when the Arena-1 is described and is given to these patients' cells in a test tube. And what we can see is that also this effect is superior to what happens with hypertonic saline. So many of you patients will be taking hypertonic saline. This means this drug at least in the test tube, is superior to the effect of hypertonic saline. So it may be a more effective agent like a mucolytic, which helps to clear mucus and dissolve it to some level so it can be transported out of the lungs more easily and help with symptoms. And so we have been fortunate to be able to study in what's called a phase 2A trial in several centers across the US. The effect in non-CF bronchiectasis, and found we have reductions in symptoms in these patients and a good safety profile for this drug. And so we hope this drug will move forward through what's called a phase 2B, which will be an additional medium-sized trial, or a phase 3 pivotal trial in the future. And so with these kind of introductions to various clinical research areas that are happening in bronchiectasis, I'm going to turn to one forward-facing slide. And this is a slide demonstrating there are several what we call endotypes in bronchiectasis. An endotype is where you pair a phenotype of patients, either disease state or a particular characteristic of them, with something about the laboratory findings, like something in their blood or something in their sputum or other aspects of the disease. And what we can see is that various investigators, as described in this summary figure, are looking at these different endotypes as ways we can target. And so some of these endotypes have motivated just this small list of therapeutics that are being studied to think about this, including asthma biologics that can be used for eosinophilic type bronchiectasis, which is where another cell called the eosinophil tends to invade the lungs and causes increased inflammation. Agents that affect the mucins, which are components of the mucus itself. Genetic therapies for certain diseases like primary ciliary dyskinesia and other diseases. Treatment of the microbiome, which is kind of the spectrum of the microbiology in the lungs and the organs of the body, and a host of other type of therapies that are being studied at the earlier level. And so you may be seeing these types of endotypes if you're fit into that patient population, or these types of therapies approached to use as a potential therapeutic target clinical trial in the future. And so I'm going to end with concluding that we're advancing a better understanding of the interplay of the we call pathophysiology, or the disease mechanism, and clinical outcomes in non-CF bronchiectasis. You'll hear a bit more about neutrophil-derived proteases such as brensocatib and others we introduced briefly, and a really an enhanced understanding of the disease mechanism, which is really central to understanding the development of therapies. Is leading to better therapeutic options now, and a host of what we call exploratory therapies. So really an explosion of clinical research in the area of bronchiectasis now and in the future. So I hope you guys will stay engaged on that, learn ways to be engaged with your team about it, and hope you'll explore the potential of being part of a therapeutic clinical trial in the future. Thank you very much.
Hi there, my name is Pamela McShane, and I'm a pulmonary and critical care physician at the University of Texas in Tyler. And that was an absolute tour de force talk by Dr. Solomon. I think you could watch that, 10 different times and get something more out of it with each time you've viewed that talk. It was fantastic. A big portion of what I do every day is offering people with bronchiectasis the opportunity to engage in clinical research trials. So I think to that regard, it's important that I point out that I did serve as a principal investigator and an advisory board member for both of the companies who've made dipeptidyl peptidase inhibitors. There were hundreds of people signed up to watch this webinar today. That means hundreds of unique individuals. And similarly, I'm showing you 6 representative images of all of my unique patients, but what they all have in common is bronchiectasis. And as Dr. Solomon very clearly pointed out, what they share is this common pathogenic events that occur either in the airway in terms of the mucus and the way the airway behaves to process the mucus and move the mucus, also chronic infection, and neutrophilic inflammation. And so my focus right now is to talk to you about the neutrophilic inflammation. Neutrophils are extraordinarily important, and they are the most common white blood cells in our body. They are the first responders for bacteria and fungus, and they kill these bad organisms by multiple mechanisms, but namely they ingest the bacteria. That's called phagocytosis. They release antimicrobial substances. Hold that thought because we'll come back to that. And they secrete these traps that can immobilize and kill bacteria. If you're thinking about Spider-Man, you're accurate because that's what these things can do. They're extraordinary cells. With regard to the substances that they release, specifically, I mean, there are lots of them, but specifically for the purposes of this talk, some of them are neutrophil elastase, proteinase 3, and cathepsin G. So we have this fantastic cell. It's common in our body. It's there to fight infection. So why the heck are you constantly fighting these infections? It's a conundrum that we have every day. And I'm showing you on the right-hand part of this slide, a specimen from a patient that has already been decontaminated for bacteria and is now being cultured for non-tuberculous mycobacteria, but that Pseudomonas is overgrowing that culture. It has no business being there. And so what the heck were the neutrophils doing in this patient? It's a very common problem. Well, scientists who study this in the field of bronchiectasis have identified that neutrophils are kind of reprogrammed in bronchiectasis patients. The phagocytosis is not working correctly. They're not really killing bacteria the way they would be expected to, and they're also not really dying on time. They're lingering in our system. And that's really important, that delayed dying, because they are still secreting those substances that are supposed to act as antimicrobial proteins, but instead those then turn and can become damaging to the airways. So you have these neutrophils that are not really effective in killing the bacteria, but they're also secreting these substances that are collaterally damaging the airway. And so there's this yin and yang of neutrophils. They fight infections, yes, but they're not quite on pace with what they're supposed to be doing in the bronchiectasis patient, and therefore they're causing collateral damage. So specifically, if you look at the levels of these antimicrobial substances, or specifically neutrophil elastase, the levels of those correlate with the severity of bronchiectasis. So I'm showing you here 3 graphs. From the left, the graph on the left is showing the severity of bronchiectasis as calculated by something called the Bronchiectasis Severity Index. The lung function is shown in the middle graph, and to the far right, I'm showing you exacerbations delineated by showing exacerbation-free time that the patient experiences. So the higher curve on that graph is the best. And in each one of these graphs, the highest, as neutrophil elastase goes high, the outcome is worse. So high neutrophil elastase correlates with more severe bronchiectasis. High neutrophil elastase correlates with worse lung function. And high neutrophil elastase correlates with more exacerbations over time. So this has become what we call a marker of disease, neutrophil elastase. And it's not quite to the point where you can go in and ask your doctor to measure your neutrophil elastase, but it's become sort of an academic marker of disease and how we can follow the severity of the disease. Something really important to understand about neutrophil elastase is that it has to be activated in order to cause damage. And what activates it? Well, dipeptidyl peptidase 1 is a protein that activates the neutrophil elastase. So dipeptidyl peptidase 1, or DPP1, now becomes a very opportune target to inhibit so that these potentially damaging substances can't exert their influence on the airway. And enter the dipeptidyl peptidase inhibitors. Brensocatib was the first one that we studied. So brensocatib locks in to the dipeptidyl peptidase, and it makes it so that it cannot activate those substances that come out of the neutrophil, specifically cathepsin G, proteinase 3, and neutrophil elastase. So there are now 2 dipeptidyl peptidase inhibitors on the market, brensocatib and BI 129-1583. As you probably know, brensocatib was made by Insmed. It is now successfully moved through phase 2 and phase 3 trials. and it's going to be presented to the FDA this August. 129-1583 doesn't get to have a name yet. It will soon, but for now we call it a number. That's made by Boehringer Ingelheim, and it's successfully completed phase 2, and it's gearing up for its phase 3 trial. And that phase 3 trial has some special inclusion factors, which I think are important to learn about today. So for the moment, I'm going to go back to brensocatib and tell you a little bit more about brensocatib. So brensocatib is an oral drug. It's once a day. It's selective for its target. It is reversible. So when the person stops taking the drug, the effect goes away. And as I mentioned, it's successfully completed both phase 2 and phase 3 trial. The details of the phase 3 trial were that it included over 1,700 patients, which is a lot, given the fact that bronchiectasis is still considered a rare disease. The patients received either 10 milligrams, 25 milligrams, or placebo, and they were studied for up to 52 weeks, depending on when they came into the trial. And the primary outcome here was measuring the exacerbation risk in these people who received brensocatib. So I'm repeating those same words on the left-hand side of this slide so that you can refer to it. But I'm showing you on the right-hand part of the slide that outcome was important. It reduced exacerbation risk by 20% in people who received brensocatib. And now this was super exciting for us because bronchiectasis trials have had a tough time, and we've had a tough time proving that the study drugs have really demonstrated a consistent reduction in exacerbation frequency. And this is the first drug that has shown this. And so this was really something for us to celebrate. In addition, what was very provocative about this trial was that a secondary outcome looked at lung function. Most of you probably have been told by your doctor that lung function stays pretty much the same in bronchiectasis. We don't get a lot of movement the way sometimes the lung function can get better and get worse as it does in asthma sometimes. In bronchiectasis, it stays the same. And what's even worse is that we all lose lung function every year after 30. But patients who have lung disease lose lung function at a more rapid pace than a normal person, a person with normal lungs. So it looked like in the brensocatib study, patients who got the higher dose demonstrated a reduction in the normal decline of lung function that's seen in people who have bronchiectasis. This was incredibly provocative because, as you know, we all have to lose a little bit of lung function, but you want to hold on to everything you can. And this was only over 1 year. How would it be if you took the drug for much longer? So this is an area of incredible interest, and we're looking forward to seeing how this goes in the future. In addition, brensocatib improved quality of life in people who received the drug. You can see the 3 different trajectories here of people who received 25 milligrams of drug. That was demonstrated in the middle, light blue. 10 milligrams received the highest improvement in quality of life. And also, interestingly, people who got placebo had a small improvement in quality of life. This is something that we see frequently in bronchiectasis trials, and I want you to hold that thought because we'll come back to that in the next 2 slides. So brensocatib will be presented to the FDA in August. We're all eager to hear what the FDA decides. And if it receives a positive review, this will be the first FDA-approved drug for bronchiectasis. We're now moving on to 129-1583. That is the other dipeptidyl peptidase inhibitor, and this drug is made by Boehringer Ingelheim. I mentioned that it has just finished its phase 2 clinical trial. It was also a positive trial, and it demonstrated all similar findings to what brensocatib showed. It improved exacerbation risk, so less risk of exacerbations if you receive the actual drug. Also demonstrated a reduction in the decline of lung function and improvement in quality of life. So this was an exciting findings because it sort of bolstered the concept that dipeptidyl peptidase inhibitors actually have this positive effect, because now this is the second trial of the same mechanism that demonstrated these findings. Therefore, this successful phase 2 now gives the drug the opportunity to go on to phase 3. So the phase 3 of 129-1583 is called the AirTivity trial. This is the phase 3 trial. Patients will receive 2.5 milligrams or placebo, and this is going to be longer. It can go up to 76 weeks. So some of these signals that we're seeing with lung function, we'll get to flush them out for a longer period and see what happens. The other unique thing about the AirTivity trial is that it's going to include a more broad patient. So Bronchiectasis was a little bit more restrictive in which type of patients it included. For one, patients had to have 2 or more exacerbations in the prior year. In AirTivity, they only have to have 1 exacerbation as long as they have a certain high level of symptoms. And then also this study will include patients who have cystic fibrosis, patients who have COPD, patients who have asthma, and many of these patients were excluded from the Bronchiectasis. So we're going to look at a more broad population. But you may ask, well, then why would I enroll in a phase 3 trial when maybe I can get the drug from market? Well, I would argue that it's really important to have this confirmatory trial. In addition, it's going to include a broader group of patients. And we see this consistently, not just with these studies, but with all studies in bronchiectasis. Even patients who get the placebo demonstrate an improved quality of life. And why is that? Well, it's probably because you get to see your doctor more frequently. You're more engaged. You're doing your other airway clearance things more often because you're constantly reminded that you're in this trial. We don't know for sure, but we definitely see that patients, even if they get the placebo, they do well in clinical trials and often have an improvement in their symptoms. So in summary, neutrophils are extremely important. I don't want to deliver the message that just because there is a collateral damage that comes from them, that they're bad. They're very important. It's just unfortunate there's 2 sides to that inflammation. Neutrophil elastase is a substance that's produced by neutrophils, and higher levels of this neutrophil elastase correlate with more severe disease. And Bronchiectasis and BI 129-1583, these are both oral pills. They prevent the activation of neutrophil elastase, and they can reduce the risk of exacerbations, improve quality of life, and reduce the decline in lung function. And participation in a clinical trial not only will move our field forward, it may help someone who's coming up behind you, maybe your relative who might have bronchiectasis, and it may even help you as part of being involved in the trial. So thank you so much for listening, and I wish you the best.
Right, thank you. And I want to say thank you to all of our speakers. That's a lot of material. I hope that was of value to everyone. I'm gonna now try to look at some of the questions that have been submitted.
I have a lot written down. I'll give it.
Okay.
Dr. Sullivan and I have answered some of them, but some came up multiple times.
All right.
The first question is easy. How soon will the recording be available? That's come up multiple times.
Stop the share so we can see them. So one question is this has been recorded. As soon as we finish this session, I will stop the recording and then we'll try to get it posted just after the weekend. So the intent is it will be posted on the Bronchiectasis and NTM Association's website. So once we get the link to them, I will ask them how quickly they can get it up.
All right, next question. Should cystic fibrosis testing be part of the workup for bronchiectasis? And if so, should that be sweat chloride or genetic testing?
So I will give you my thoughts, but I'm going to actually invite a couple of other speakers to offer theirs. Because one of the big issues that one needs to think about is what is the proper evaluation of a person with bronchiectasis. So there are scats of etiologies or potential etiologies of bronchiectasis, and cystic fibrosis is one. On the one hand, most of the patients with CF that we diagnose, whether by newborn screening or by symptoms, are identified early in life. But even before newborn screening, about 4 to 5% of patients survive until later in life, until their adulthood. The other thing we know is that cystic fibrosis gene mutations are found more commonly than in the general population when you look at specific populations like bronchiectasis. Most of the people, if we test them, are not going to have cystic fibrosis. But you heard a compelling question about whether the CFTR modulators might have some benefit in these patients. And so looking for an opportunity to offer them therapy that might be their benefit is intriguing. So it has not been our practice at MUSC to test every single person for cystic fibrosis, but that may be different from others. So I'm going to start by asking Marty to come up and share your opinion. And then Ken, when Marty finishes, I'm going to ask you to render your opinion.
So I think, first of all, it's a really good question, and it's one that we don't have an exact answer to. I would say that in general, the approach is two-pronged. One is, as Patrick was saying, I'm saying, do we need to know if this is cystic fibrosis or not? The only way to know something is definitely not cystic fibrosis, if there's a high suspicion, is to look at both confirmatory genetics or a sweat chloride test. So if you want to be sure about absence or presence of a diagnosis of cystic fibrosis, really need to have either genetics, which are diagnostic, which sometimes they are. In many instances with patients that are older that don't have what we call classic cystic fibrosis, or that which was present from birth, in terms of symptomatology, that won't be the case. And so the sweat chloride or other testing of the CF protein function can be necessary. If the question is to look for association, then I think genetics may be adequate, because oftentimes the association and whether or not you have maybe a gene or we call a carrier, which means that you have 1 or 2 copies of an abnormal gene, or a variant, we call them in more modern terms, that can be necessary. That can be all that's necessary. You don't have to do sweat chloride. But I think the point is, it's best if you have firmly established the diagnosis of CF, because there are specific therapies towards that diagnosis. So we oftentimes will screen with the genetic sequencing panel in patients that we think have a high suspicion of a genetic type illness. And that's patients that may have infertility, especially male infertility, or severe sinus disease, or have had severe infections like severe Pseudomonas with sinus disease. Those things oftentimes go along with having cystic fibrosis or other genetic diseases which are similar to cystic fibrosis, like primary ciliary dyskinesia, especially in our patients that are in the younger set of our patients we see, the ones we tend to very much screen for, and we'll go all the way through the diagnostic approach. Others may get a screening with genetics depending on our kind of thought process, but it's not necessary on every patient, as Dr. Flume alluded to earlier.
Thank you, Marty. Ken?
So our approach at UNC is very similar to that, particularly in patients that have NTM. There have been studies that have shown in cystic fibrosis patients who are over the age of 40, that the vast majority will have experienced NTM infections, and that the patients who are diagnosed later in life are more likely to be in that group. And so that kind of increases the likelihood of patients with bronchiectasis and NTM that there could be a misdiagnosis of cystic fibrosis. Now, it's not going to be that common, but we do, similar to Dr. Solomon, and use a genetic panel screen for that. We recognize that depending on sort of racial and ethnic backgrounds, which have variations in the prevalence of cystic fibrosis, those panels may miss certain mutations in CF. So having a negative panel does not completely exclude that, but it's a pretty good screen. If we get a single positive mutation on that, we'll then go ahead and refer that on for sequencing of the entire gene along with sweat chlorides. We don't use sweat chlorides initially just because, at least at our institution, they're more difficult to obtain. It requires a specific trip back to our institution to have that done. The genetic panel screening we can do with a blood test at the same time we're seeing the patient.
Thank you.
Can I ask a follow-up on that?
Yes.
Are you doing, when you're doing the genetic screening, what panel are you typically using?
And just in case, do you want to repeat the question?
The question was, when we're doing a genetic panel screen, what genetic panel are we using? We have a 60 mutation panel at UNC from our genetics department that is probably the cheapest that we can do to screen that. There are a variety of commercial panels out. Some of the ones that are used for prenatal screening have relatively few mutations in them. So it can vary, the panels vary in sizes, and the more mutations that are screened for, the less likelihood you may miss a significant mutation.
Okay, next
Can I
question.
make a comment about this? Yeah, so I see, a lot of
There are a lot of questions.
So I just want to comment about, sometimes your provider wants to test for CF and you're afraid of getting tested because you don't want to have that diagnosis. Actually, it's the opposite. You want to have that diagnosis because most of the time we don't know why you have bronchiectasis. And if we make a diagnosis of CF at age 60 or even 65, you probably has a mild case of CF. You probably are pancreatic sufficient, and we have a lot of things to offer you. So don't be afraid of if your provider want to test you for CF.
Next question I was thinking of answering because it was on risk for
Come on up.
NTM, so
Come
I'll
on up.
ask and answer. So the next question, I'm gonna rope in two questions that we got, which was about aspirin exacerbated respiratory disease and that risk for NTM, as well as if inhalers that include anticholinergic agents are harmful. And I would say for aspirin exacerbated respiratory disease, as well as asthma, that can be a difficult overlap. There is some evidence that inhaled corticosteroids increase your risk of NTM, but in some patients who have significant asthma, they may have to be on that. If there is not an alternative reason for being on an inhaled corticosteroid, I do often take patients off of that if they're not on it for bad asthma or maybe COPD with a lot of exacerbation. So it's a little bit case by case. In general, there's not thought to be significant harm with anticholinergics. Some patients feel like it dries up their sputum. So in terms of which inhalers you're going to be on, that's very dependent on which other respiratory diagnoses you may have and your physician. But we do try to stay away from inhaled corticosteroids unless you have another diagnosis leading to it. The next question, it's two questions for Dr. McWilliams. These came up when you were talking. So one question is if there are ways to mitigate risks from antibiotic side effects. For example, do vitamin D or NAC have any role there? And the second question came up with a couple patients who were worried when you were talking about supplements possibly interfering. Patients may be on supplements for osteoporosis, for example, and is that something that they have to worry about? They do understand that we can't get into each patient's specific case, but just kind of in general.
Sure, all great questions. So we don't have really any hard evidence to recommend vitamin D or NAC. So my answer to that would be no. As far as the supplements, it's a great question. So I think it's an individualized discussion with the provider. There are some antibiotics where adequate absorption is inhibited or interfered with, for example, omadacycline and calcium at the same time is a no-no. But if you actually space them out, the rule is at least 2 hours before or 2 hours after is okay. So I think for those individual circumstances, just important to talk to your provider and treatment team, and then they can always suggest strategies to work around some of that.
The next question, I think probably anyone could answer, maybe you want to answer, Dr. Flume, is with NTM, how do you develop antibiotic resistance do you automatically have that? And if you take a shorter course of antibiotics, for example, if you have to go off of antibiotics before you finish treatment because of side effects, does that increase your risk of resistance?
Okay, that's a difficult question. So in terms of resistance, keep in mind that it is not the patient that becomes resistant to the antibiotics. It can be the bugs that are becoming resistant to the antibiotics. Exposure to well, first off, most of the organisms that we see, certainly with mycobacteria, tend not to be overly resistant to the antibiotics that we have available to us. It's not a big collection of drugs we have available, but generally speaking, we don't find de novo macrolide resistant, aminoglycoside resistant organisms. So what can happen is selection of those bacteria developing resistance. So contained within that, you expose antibiotics to an organism, you can kill off those that are more susceptible. What can be left are those that are more resistant. So we do worry about improper use of antibiotics in those settings. So too short a course might be a problem. So in general, we don't like it when people have stocks of antibiotics that they treat themselves without us knowing what they are, and generally want to use them. On the other hand, prolonged use of antibiotics for typical bacteria is also not recommended because you're exposing other bacteria to these drugs that you can now select out resistant strains. The challenge for us is the way mycobacteria behave. Because of the way they behave and the way the antibiotics work against them, that's a big reason why we have to go with prolonged duration of exposure, because these bugs are relatively slow to do anything, and so you've got to keep drug in the space to kill the bugs. So we do worry about resistance. We are doing our best to try to make proper guidance in how you take the antibiotics, and you just got to communicate with us to know how you're doing with them and whether changes are necessary.
There's 3 questions around cavitary disease. I don't know who wants to tackle that. The 3 questions are, is there a way to predict rate of growth for cavities? Have we ever seen cavities go away on their own? Is there a recommendation for surgery for cavitary disease?
And I'm going to tackle the first 2, and I'll just assume we have consensus. So the first question is there any way to predict rate of growth? I'm just going to say no. The second question is, do cavities ever go away? The answer is yes. Having said that, many of the people that have cavitary disease, it's a difficult thing to resolve. And so making the cavity go away, at least in our hands, is not a primary goal. That is not necessarily a sign of success. But I'm going to toss the question about surgery to who wants to tackle the surgical question. Ken.
So I think the question regarding do they go away on their own, I'm not sure they go away on their own. I mean, some cavities do resolve on medical treatment. Surgery we generally reserve for cavitary disease that does not respond to medical treatment, and that is what we call amenable to surgery. So if someone starts out with really bad lung disease, and then to get the cavity out, it requires taking out part of the lung that may still be functional as well. That may not be a great recommendation for that patient. There are other surgical risk factors that need to be considered, such as we talked about low body mass index or low underweight patients with poor nutrition that increases surgical risk. But in patients that have cavities, the reason to be concerned about those is that frequently those cavities wall off mycobacteria or protect it from antibiotics. Because the blood flow may not be great to the inside of the cavity, the organisms can multiply on the inside of the cavity and then theoretically spill to the rest of the lung. So we try very hard to treat cavities aggressively. If they don't respond to medical treatment, and those patients are appropriate surgical candidates, we'll frequently refer them for surgery.
2 more questions. I really like the last question. For NTM, MAC, the question was about MAC, but I guess for NTM in general, how do you decide for watchful waiting versus treatment?
Okay, Alice, do you want to tackle that one?
So I would say, perhaps in the past, we used to do more watchful waiting compared to active treatment, but in 2020, there's a new set of guidelines that were released to urge us to actually probably reconsider this approach and be a little bit more aggressive in treating those patients. So we do look at risk factors to tell us maybe we should consider treatment now versus waiting. And one of them is, as Dr. Olivier mentioned, low body mass index. So if you have a malnutrition or low body mass index, it's a sign that we should start. Having a cavity, we should not ever wait on a cavity, we should start. If we are doing sputum culture and the smear is positive, so when you submit sputum culture, we usually do something called a smear first, and then we grow it on the culture media. So if right off the bat, the smear is positive, that imply a larger burden of the disease, and the guidelines urge us to actually consider treatment. If we have blood work showing that you're inflamed, we sometimes test for a lab that's called CRP, C-reactive protein. And if you are inflamed, that's a sign that we probably should consider treatment. And we have significant or multifocal disease, meaning multiple lobes are involved. That typically is a sign that we should, pull the trigger and start treating.
The last question is for Dr. McShane, and I thought it was a great question. Do these new drugs lower your immunity like steroids if they're acting in the immune pathway?
I was a little limited by time, so I wasn't able to add the safety data. And so thank you for asking this very important question. In all these clinical trials, and by the way, this is why clinical trials are so important, and not to utilize drugs that have not undergone placebo-controlled clinical trials, is that safety is a big part of what's monitored throughout the treatment course. So the first thing is there was no increased signal in pneumonia in patients who received the dipeptidyl peptidase inhibitors. So more frequent infections were not seen in people who received the actual drug. The other important thing to know is that there is a syndrome called Papillon-Lefèvre. I have a dreadful French accent, so that's the best I can do for that one. It's a syndrome in which people don't have dipeptidyl peptidase at all. And so that serves as what could happen if you really tremendously inhibited the dipeptidyl peptidase. These patients who have Papillon-Lefèvre, they have rash of the hands and the feet, skin peeling, and they have periodontal disease. We did not, at no clinical centers, see a signal that suggested that this dipeptidyl peptidase inhibitor caused a syndrome similar to Papillon-Lefèvre. So that was also very encouraging. However, if you were in this trial, you probably knew that we looked very closely at skin on the feet and the hands, and all patients were evaluated by a dentist during these clinical trials. So we really do have good safety data, and you should feel confident that these drugs have been evaluated very thoroughly for safety.
All right. Well, I want to say thank you to you all for paying attention and joining us. I want to say thank you to all of our speakers. They are representing many of the sites that are part of our Southeastern Consortium. So we look forward to the work that we've talked about today and bringing that forward and sharing it with you in the future. So thank you all and take care.